Everyone. We are live from Baltimore, Maryland. I'm Rifat Manan, and welcome to this edition of Patcast. Today we continue our GI pathology
We are
series
live
from the
from
Johns
Baltimore,
Hopkins
Maryland.
Department of
I'm
Pathology,
Rifat Manan.
and we are joined once again by Dr. Lysandra Voltaggio, who will be present her talk entitled Colonic Polyps. As always, you are more than welcome to ask questions by typing them as comments right here in the Facebook and YouTube video windows, and I will make sure to pass those questions along to Dr. Voltaggio at the end of the session. With that, I will now pass the microphone over to Dr. Voltaggio. Thank you, Dr. Voltaggio.
Thank you, Dr. Manan, and thank you for arranging this and making this possible. So today's lecture, we're going to be talking about colonic polyps, which is something that it's basically our daily bread in the GI mucosal service. And even though most of them are no big deal, tubular adenomas, hyperplastic polyps, many of them can be challenging or unusual. And we're going to be concentrating mostly on spindle cell polyps in the colon. And then if we have time, we'll visit one or two issues that keep popping up in the consult service every once in a while regarding epithelial polyps. But let's start with our first case, which is 50-year-old male with a screening colonoscopy. And this was a polyp of the sigmoid colon found during routine colonoscopy. And this is what we see. Can everyone hear me okay, first of all, before I go on? See if anyone comments or answers. All right. Well, if people can't hear me, just write a comment and let us know. Anyway, so this is our first case. And from low magnification, we can see that it looks very eosinophilic and very pale, very pink. So that means it's a hypocellular lesion, polypoid lesion of the colon. And yes, there's a little bit of associated colonic epithelium with lamina propria, very little of it. So the bulk of the lesion is devoid of colonic glands. And here we can see it a little bit closer magnification, and we can see that it's composed of spindle cells, very far away from each other. So it's a hypocellular lesion, tons of pink eosinophilic cytoplasm. And let's look at the nuclear features. So they're nuclear bland. Chromatin is not really hyperchromatic and smudgy. No mitotic figures. So in this setting, we assume that, since this was an endoscopic biopsy, this was probably obtained, this was obtained endoscopically, so this is a lesion that arose in association with the muscularis mucosa, because the endoscopist is not able to go as deep down as the muscularis propria, technically, usually, to obtain any material. If they do, it's problematic because they may perforate the patient. So when we see lesions like this, pink, eosinophilic, smooth muscle-like. So if you were in the uterus, say, you would be thinking this is a leiomyoma, and that's exactly what this is. So leiomyomas are typically obtained during routine colonoscopies. Typically in males are a little bit more common than in females. But there are lesions that are hypocellular, and they look just like leiomyomas anywhere else in the human body. And yes, you could do stains on them if you're worried about it, or if you haven't seen that many. You can do the CD117 to make sure you're not dealing with the GIST, but these are typically unnecessary when the morphology is similar to what we're seeing here right now. GIST are typically not obtained via endoscopy or via colonoscopy, because these are lesions typically associated with the muscularis propria, not with the muscularis mucosa. That's not to say that it can't happen. In the 7 or 8 years that I have been practicing, I've seen one case of a GIST associated with the muscularis mucosa, but it looked completely different from this. And unfortunately, I don't have the slides here with me, but it looked like a typical GIST, very hypercellular, with a couple of mitosis. And on immunostain, it was diffusely positive for CD117, negative S100, et cetera, et cetera, et cetera. So when you see a lesion such as this, you can feel completely comfortable by calling it a leiomyoma in the absence of any additional immunohistochemical or ancillary tests. But if you do feel compelled to do it, you can you'll find that these are typically SMA, diffusely immunoreactive, and some of them are also desmin immunoreactive as well. They are completely benign, and they do not require any endoscopic follow-up or continued endoscopic surveillance if this was the only lesion that was found via endoscopy without any associated adenomas, et cetera, et cetera. So this is to contrast with leiomyosarcoma of the GI tract. And this is, I'm a little bit cheating here because this was seen in association with the stomach. I couldn't get my hands on, I have one leiomyosarcoma later on in the colon, but since they are so rare. And you can see here that there's a big difference in terms of cellularity and in terms of what the lesion is doing to the overlying mucosa. You can see here that it's effacing the overlying mucosa and replacing the lamina propria and splaying the normal gastric glands apart. Besides that, the cellularity is much more, the lesion is much more cellular, it's less pink, more blue, quote unquote. And then when you look on higher magnification, you can see that the cytologic features are different. The cells are a little bit larger and importantly, more atypical and hyperchromatic. And this lesion was rich, had prominent mitotic activity as well. And here, it doesn't take a long time to find the mitotic figures. So here's one. And let's just walk a little bit more. And it's an important distinction because leiomyosarcomas of the colon are can be aggressive neoplasms. There haven't been that many reported. A paper by Mietinen and colleagues, they were able to amass 7 cases, and 5, I think, of those patients died of the disease. The patients who interestingly lived, their tumors were polypoid, and they were, pedunculated. So hard to say based on the number of cases whether that had anything to do or not, but just a note. So difference in cellularity, differences, a much more cytologically atypical lesion, nuclear hyperchromasia, mitotic activity, overlying destruction of the mucosa and replacement of the lamina propria by the lesion, et cetera, et cetera. So that was in the stomach, and this is an example of a colonic leiomyosarcoma obtained during endoscopy. And again, let's look at the first case again. On low power, a very pink, very hypocellular lesion, first polyp, second polyp, or third polyp, a bluer, more hypercellular lesion that when you look closer, you can see it replacing, effacing the overlying mucosa and pushing the colonic glands apart. And when you look at the cytologic features, there is nuclear hyperchromasia and atypia. And I don't think there were any mitotic features here, but this is a small biopsy. So you can see the hyperchromatic nuclei here. So this was diagnosed as leiomyosarcoma in the colon. And here's the SMA, which is diffusely immunoreactive. Now, does SMA, diffuse immunoreactivity in the absence of the cytologic morphologic features, make it for leiomyosarcoma in isolation? Of course, the answer is no. Here's another example. This is, I want to say, a 50-year-old female with, this was called a polypoid lesion. And most of the polyp consists of abundant necroinflammatory or fibrinoinflammatory debris, which kind of makes you worry there's something going on. Anytime you see this, you consider the possibility that there might be something scary or atypical in the background. And then so we see it associated with the spindle cell proliferation, which here at first blow you can see mitotic activity, not a problem. And let's see, we have more of it. I think there was another piece. Yep. It's rather cellular, more cellular than the first example that we saw. But let's look at the cytologic features. So abundant cytoplasm, the chromatin is not really smudgy, hyperchromatic. It's really open and almost vesicular. Nucleoli are not really prominent. Yes, there's more mitotic activity, And then the background is that it's inflammatory. So we can see some neutrophils, some lymphocytes associated with this lesion. So, I mean, you worry, what are we looking at? Are we looking at a neoplasm? Or are we looking at something reactive? So we stain the lesion, and here's the SMA. So the lesional cells are immunoreactive with SMA. Okay, so let's look at the Desmin. Whoa, so it's diffusely immunoreactive for Desmin as well. So is that enough for us to say this is a leiomyosarcoma? And the answer is no. In the absence of the morphologic cytologic features, we have to be careful. We go in the chart and see, okay, let's see what else do we know about this patient. So this patient had a history of a colonic resection. I believe it was about a year or maybe 6 months before this. And this polyp was at the anastomotic site. And by the way, this was CD117 negative as well. And this polyp was an anastomotic site. So we thought, you know what, this is probably a reactive fibroblastic / myofibroblastic proliferation because of probably ischemic changes, some sort of ischemic change at the anastomotic site. But you know what, we weren't completely sure because this looked like a real, lesion. And what if we were missing something that was neoplastic that we can really call on the first biopsy? So we said, we favor reactive, but follow up the patient. The patient was followed up 3 months later, and the lesion had decreased in size and felt soft to the touch. So the endoscopist was reassured that this was probably a reactive lesion. It looked very, very, very similar, with also an associated fibrinoinflammatory reaction. And some patients just develop this kind of reparative processes with spindle cell proliferations that can look myofibroblastic without a lot of significant cytologic atypia, that can look worrisome for inflammatory myofibroblastic tumor or a GIST. And they're just reactive processes in patients who are prone to those reparative changes. Occasionally, these same types of lesions can have some cytologic atypia and provoke concern. This was a case that we received in the consultation service, and it was seen colonoscopy as a polyp. And you can see here that at the surface, the cytologic features are very similar. Of interest, the lesions that we've seen, these types of lesions, when you look at the surface, the lesional cells are almost always arranged perpendicular to the surface for some reason. And then when you go deeper down, you can see a little bit more epithelioid appearance, a little bit more of cytologic atypia, but still punctuated by inflammatory cells, including neutrophils and lymphocytes and plasma cells, a couple of eosinophils. Some of the cells are more vesicular with more atypia and more prominent nucleoli. In the 80s and 90s, these types of lesions were assigned, when they had this degree of atypia, were assigned terms such as pseudosarcomatous change or bizarre reactive stromal cells in these kinds of cases. Also, these can be seen in the setting of IBD as in patients with injury as a result of IBD, or in patients with injury as a result of radiation. We have seen also these proliferations associated with frank carcinomas, and we've seen one case misdiagnosed as combined leiomyosarcoma and adenocarcinoma. And they're simply reactive proliferations that some patients develop in association with their malignancy and not necessarily a quote-unquote collision tumor. And the tricky part is, as I showed, that they can be SMA, Desmin, immunoreactive, but that varies. Some of these lesions are negative for everything, except of course for Vimentin, which almost everything is positive for. So continuing our spindly, any questions about any of those lesions? No? Okay. So continuing our spindly topic, This is a polyp that is uncommon in the colon, but here we have one such example. These are typically more common in the stomach, in the small bowel, and what I teach our residents and fellows is that this is a kind of polyp that when you look and you put it under a microscope and you go and look in low magnification, it's a pale polyp. This one is a little bit more darker than usual, but you can see some pale areas surrounding the vessels. It's almost as pink as a leiomyoma, as the leiomyoma that I showed initially, but different and low power from a leiomyoma. You see from this magnification some prominent vessels. So we look at higher magnification, and the lesional cells are spindly. It's not a very cellular lesion. Plump, pale, at most pinpoint nucleoli, abundant cytoplasm. And one thing that this particular example has a lot of is this onion skinning around the vessels that sometimes when we look at these biopsies, we struggle to find just because I want to show it to my trainees. But in this example, it's actually very prominent. And we're looking at an inflammatory fibroid polyp. The other thing that we see is an associated inflammatory component that is rich in eosinophils. Are eosinophils always present? I want to say yes. Is it always, always, always? I want to say almost always. The thing that it's variable. If you look for them, you'll find them here and there, and some of them are very, very eosinophil rich. But that's a good thing to see when you're thinking about this entity in one of these colon polyps. So these are completely benign. As you can see here, their epicenter is in the submucosa, but they can involve the overlying mucosa and even provoke some ulceration, and that is not indicative of malignancy. The vast majority of these polyps occur in the stomach, as I just said, and many of them also occur in the small bowel. When they occur there, patients typically present with intussusception. Very rarely do we see these in the colon. So how do these stain? And number one, do we have to stain these? No. When you have perfect or adequate morphology, you can call them without staining them. If you do stain them, these can be SMA positive, they're desming negative. What they're almost consistently positive for is CD34. And I say almost consistently positive because the smaller lesions tend to be more consistently positive than the larger ones. So I've seen large lesions where CD34 has been either partially or completely lost. So I wouldn't be surprised if this big Goomba lost all of the CD34 immunoreactivity, and that's completely fine. So in summary, plump, bland, spindle cells with associated peppered eosinophils and good onion skinning around the vessels in some examples. So every once in a while, we'll get a treat on the mucosal surface, and where we see them really small, and I'm sure Dr. Rifat Manan recognizes this case because we had it during one of our sign-outs, and this was submitted as a colon polyp, and we couldn't really call it, a tubular adenoma, nothing in the epithelium to suggest any epithelial process, but there was something down here going on. And we can see these bland spindle cells, not a whole lot in the way of onion skinning, and perhaps a few eosinophils here and there, not a whole lot. So we thought this was probably an inflammatory fibroid polyp, and we did our CD34 stain, which confirmed our suspicion. So here's an immunostain. So very, very rarely seen in the colon, sometimes large as the first example, and sometimes very, very tiny and subtle. So they can happen. All right, another spindle cell treat, which is more common than the inflammatory fibroid. And by the way, inflammatory fibroid polyps associated with PDGFR alpha mutations. Forgot to mention that. So our next spindly polyp, also occurring in the distal colorectum, also an incidental finding, just like the leiomyomas. Also of no clinical significance. Patients with these types of polyps do not require increased surveillance. The only thing that you have to do is learn how to recognize them. And we can see here that it's a proliferation of spindle cells that is playing the colonic glands apart, replacing the lamina propria. Let's look at the cytologic features. Abundant, pink, wavy cytoplasm, somewhat tapering nuclei, bland, no prominent nucleoli, no mitotic activity. And when I see things like this, I think of mucosal Schwann cell hamartomas, which were described by Dr. Hornick and Gibson back in 2009. These are typically diffusely S100 immunoreactive, as you can see here. And what's the differential diagnosis? So the differential is with neurofibromas. The difference between neurofibromas and mucosal Schwann cell hamartomas is important because mucosal Schwann cell hamartomas are not associated with syndromic states, but neurofibromas are associated with NF1. So that's something to keep in mind. The other thing is that neurofibromas are exceedingly uncommon, and mucosal Schwann cell hamartomas are much, much more common. On morphology, there's mucosal Schwann cell hamartomas have a little bit more or less lesional heterogeneity, while neurofibromas have more lesional heterogeneity. Of course, neurofibromas are S100 positive as well. And actually, I have an example of a neurofibroma here from it's very old example from our files. And you can see that on H&E, they're actually rather similar lesions. But if you do an S100 of neurofibromas, you are going to see patchy immunostaining as opposed to diffuse immunoreactivity. As opposed to diffuse immunoreactivity.
I think we have one question from one of our previous fellows, Dr. Arvind Rishi. So he has this question, I think related to this case. So on a biopsy, can a wall of hamartoma with granulation tissue-like response look like this? So recently had a case with similar morphology, but endoscopists thought of it as hamartoma on endoscopy.
Kind of what?
Can a wall of hamartoma with granulation tissue-like response look like this?
Oh, a wall of a hematoma. Sorry, I thought you were saying hamartoma. With granulation tissue-like response look like, oh, the spindly reactive thing?
Dr. Morris, you have
Yeah,
call
definitely.
13303.
Yeah.
Dr. Paul Morris.
All right. So
133.
we're talking about neurofibromas. So by morphology, they're actually rather similar. So if you do the S100 is going to be patchier, and it's not going to show that diffuse immunoreactivity that the Schwann cell hamartoma has. The other thing is that if you do a neurofilament protein, the report by Hornick says that only 7 of their, I think, 24 cases showed scattered intralesional axons, while neurofibromas, if you do the neurofilament protein, you'll find many axons associated with the lesion. So those are 2 things that you could use to differentiate them. But again, mucosal Schwann cell hamartomas, much, much more common than the neurofibromas. And continuing with our S100 positive lesions, this can be a tricky one. So this was resected from a patient this was biopsied before it was resected, and it was called a neuroendocrine tumor. And here it is in all its glory. So the lesion is centered really here in the submucosa, but it extends over to the overlying mucosa focally, and then also extends down or towards the muscularis propria / serosa. So it's a blue lesion on low power. When you look at it on higher magnification, you confirm that, yeah, it is very cellular. Not a whole lot of cytologic atypia. The cells are kind of bland, ovoid, epithelioid. The nucleoli are pinpoint, no macronucleoli, no mitotic activity, no pigment, no calcifications, no atypia. And unfortunately, I don't have the S100 of this example because this was a consult, so we just got an H&E recut. But the S100 was diffusely immunoreactive. So these kinds of lesions were described by Dr. Montgomery here at Hopkins a couple of years ago. And this is a benign epithelioid nerve sheath tumor, which is more or less the GI counterpart of lesions described by Hart and Weiss a couple of, I think, probably last year, which were the epithelioid schwannomas of soft tissue, mainly skin. And they are S100 positive benign, completely benign lesions. Of course, the differential in the setting of an S100 positive neoplasm is always with a melanoma, but the cytologic features here argue against this. And on a follow-up, all of these patients in our series, or in Dr. Montgomery's series, showed a benign follow-up. How did this lesion stain with melan A and HMB45? It's not really clear. Because this was not included in the paper, but the ones described by Dr. Weiss, only one of about 24 cases displayed immunoreactivity with melan A, and it was pretty weak. So potentially something that you could exploit, but really the diagnosis is one that you make on H&E. In the report by Weiss, some of them have some of her cases had atypical morphology, such as vacuolated or clear cell features, and some had some cytologic atypia, not in the ones reported in the GI tract. A subset can be CD34 positive of note. So diffusely S100, CD34 positive. And typically, this is an aberrant example, but typically these are mucosal lesions with maybe a little bit of submucosal extension. But there are cases such as these that can be completely transmural and involve the underlying muscularis propria. So epithelioid S100 positive lesions, benign epithelioid nerve sheath tumor. All right. All right, so we're done with the spindly things. And now moving along with a very common issue with epithelial polyps, and we see this at least multiple times, at least 2 or 3 times during the week when we're on the consult service. And the question typically is this invasion in an adenoma, or is this quote unquote, pseudo invasion glandular misplacement? And here we have one such example. So here we have a tubular adenoma. Here we have the overlying epithelium. And then we see all these misplaced, quote unquote, misplaced glands into the submucosa. Typically, and most of them are large and round. They are surrounded not by a desmoplastic stromal response, but by smooth muscle and at least a little bit of lamina propria. So basically this polyp undergoes extensive mucosal prolapse changes, and they drag the lamina propria along with them. So whenever you see lamina propria, invasive cancers do not drag the lamina propria along with them, and instead they develop a desmoplastic stromal response. The problem becomes that these glands that get quote unquote misplaced into the submucosa can dilate and undergo striking, so they can burst and dissect. Their mucin can spill and dissect through the surrounding tissues, and they can simulate an invasive adenocarcinoma, and the dislodged cells can look sort of pseudo-signet ring cell-like, and they can provoke concern. So bear this in mind, that these herniated glands can distend burst, dissecting mucin, mimic an invasive adenocarcinoma with the mucinous and signet ring cell features. Many of these are associated, not this particular example, but many of these are associated with hemosiderin-laden macrophages, and that's also another feature that can help you distinguish them from invasive adenocarcinomas. Of course, it doesn't really make it or break it. I rely mostly on the presence of desmoplastic stromal response and also on the shape of the glands. Typically, invasive carcinomas don't have this nice, bulbous, round, big glands. I want to see small, poorly formed, angulated glands for me to call it invasive adenoma. And of course, if I have a desmoplastic stromal response, better yet. And this is another example of pseudo-invasion in an adenoma. Again, here's your overlying adenoma, and here you have your glands dissecting or herniating down into the submucosa. Some of them have undergone dilation, disruption with mucin extravasation, and dissection through the associated through the connective tissue of the submucosa. This one has tons and tons of hemosiderin-laden macrophages with associated blood. And you can see some lamina propria surrounding at least some of these herniated glands. So you can feel comfortable when you get a lesion such as this one to call it misplaced glands, quote unquote, pseudo-invasion. We typically say tubular adenoma with the misplaced glands, and in parentheses, so-called pseudo-invasive pattern in quotations. So here's another example. Again, this one has really beautiful hemosiderin-laden macrophages, and you can see the herniated glands associated with smooth muscle, lamina propria, and absolutely no desmoplastic stromal response to speak of. Nice, large, round glands, no small angulated glands, and no desmoplasia. So another example of pseudo-invasion in the colon. This event happens frequently in patients with Peutz-Jeghers syndrome, and this is from the small bowel. And you can see very, very significant pseudo-invasion and prolapse changes in Peutz-Jeghers polyps to the point where they herniate and quote-unquote invade down into the muscularis propria and sometimes out into the serosa. And here you can see the same process. So you see the herniated misplaced glands with their associated lamina propria. Let me just show it at a little bit higher magnification. And you even see dilated, exploded, or ruptured glands with dissecting mucin. So beware of these also in the setting of Peutz-Jeghers polyps. And then we get these in the consult service every once in a while because people are inappropriate. And that's another trick that you can exploit because that's not seen really in cell-ulcerated adenomas typically. So thick collagen, a thick basement membrane, thick prominent basement membrane, lots of Kolchitsky cells, the neuroendocrine cells, and mucosal prolapse, changes in a hyperplastic, in a serrated polyp with serrations only limited to the surface of the glands and tapering glands down at the bottom, so no dilations of the glands. Now, contrast and compare that with sessile serrated adenomas. So sessile serrated adenomas are of course serrated polyps whose serrations extend almost all the way down to their dilated basement, to their dilated deep portions of the glands. And some people describe them as T-shaped, some people describe them as boots. And here's a beautiful example of what you want to see in the setting of sessile serrated adenomas. According to the WHO, you only need one of these to provide the diagnosis. And I'll be honest, I'm very location biased when it comes to serrated polyps. If I see something like this located in the distal, in the rectosigmoid, so these features are perfect to me that this is still a sessile serrated adenoma. But if I see something like what I just showed, but you tell me you're in the cecum or you tell me you're in the ascending colon, I'm going to do levels on these until I find that single dilated gland so that I can call it a sessile serrated adenoma. And the reason being, I have seen examples just like this that have been called hyperplastic polyps on the right side. Fast forward 4 years later, the patient has developed right-sided colonic adenocarcinoma in the same location. So I'm typically very, very careful, and I try not to provide a diagnosis of hyperplastic polyp on a serrated lesion on the cecum, ascending colon transfers, and even the descending colon. When I get to the rectosigmoid, I'm way more liberal, but very conservative when it comes to the proximal colon. And again, and I tell my trainees, if you want to convince me, you better just do extensive levels. And even then, I probably will not call it. If I can't find that one gland, I will say serrated polyp, and I will say that the suboptimal embedding precludes definitive evaluation, but that at this location, this likely represents a sessile serrated adenoma, just because I want that patient to be followed and not have an adenocarcinoma not be missed or develop years down the road. So this, going back to the sessile serrated adenoma, so again, the dilated boot-shaped or T-shaped glands at the bottom. Let's look for neuroendocrine glands, and really not a whole lot. So here's one, a neuroendocrine cell. There may be one right there, but not as common as in the hyperplastic polyp. The collagen table is not really thick, not really prominent. The one thing that serrated polyps, including hyperplastic polyps, may associate with is with benign fibroblastic polyps or perineuriomas. Very common to see them associated with sessile serrated adenomas, and these are benign fibroblastic polyps of the colon that are typically positive with EMA and Vimentin, negative for everything else. Once in a while, you see them immunoreactive for CD34, or once in a while, you see them extending down into the submucosa. But this is a beautiful example of a perineurioma slash benign fibroblastic polyp in association with a serrated polyp. And these are bland spindle cell proliferations with plump, very pale nuclei replacing the lamina propria. And the next one is a cute little number. It's from the ascending colon. So of course, we call this a sessile serrated adenoma. I found the one dilated gland that allows me to call it an SSA, no problem. But what's interesting about this, that the pathologist that was seeing picked up on, was the presence of spiroketosis, just coming along for the ride with this SSA. So once in a while in polyps, colonic spiroketosis can be seen, and it's if the patient is asymptomatic, meaning the patient has no diarrhea, the patients are typically not treated. But if the patients are symptomatic, then they might be treated with metronidazole. In a case like this, you don't necessarily have to do special things, but if you so wish to do it, you can do a Worthing-Taxdary stain, and these are going to be highlighted in black very beautifully. Or you can do a syphilis immunostain, because these brachyspira organisms cross-react with the Treponema pallidum immunostain, and they look nice and bright on our red chromogen. So that was just an interesting finding in an otherwise run-of-the-mill sessile serrated adenoma. And then to finish with the serrated polyp, the one serrated polyp that is not a hyperplastic polyp that you see in the distal colorectum is the traditional serrated adenoma. And that differs from the SSA in terms of location. So these are typically found in the rectosigmoid, and on first impression, they're composed typically of this of finger-like projections with abundant pink cytoplasm and nuclei that are not as dysplastic as your typical tubular adenoma, but not as bland as your nuclei associated with your sessile serrated adenoma. So the atypia is in between the atypia from sessile serrated adenomas and the atypia of tubular adenomas. So the main thing that's going to catch your eye in low powers is the abundant pink cytoplasm, and what will clinch the diagnosis and what is common among all of these TSA is the presence of ectopic crypts. And basically these are crypts that grow from the sides of these filiform projections. And let me see if I can find a better area that is not, doesn't have a lot of, oh here, a lot of technical artifacts. Yeah, these are better ectopic crypts right here. And these are your, this is your ectopic crypt formation associated with your traditional serrated adenoma. These are lesions that are precursors to cancer typically. So not a lot is known in terms of the molecular underpinnings of these lesions. These have associated with KRAS mutation and CPG island methylation pathway, whereas the sessile serrated adenomas typically give rise to MSI high cancers, and also they go along the CPG island methylation pathway. So traditional serrated adenomas are distal lesions, pink abundant cytoplasm, and cytologic atypia that is in between TSAs and tubular adenomas and SSA. So we'll go back to the pseudoinvasion that people miss because of our technical problems. And here we are going to show, so the first case was, it's an example of pseudoinvasion. So you see this tubular adenoma being pulled, the glands being misplaced from the surface and being pulled into the submucosa, unassociated with a desmoplastic stromal response. The glands are round and big, no angulated glands, no desmoplasia, and they drag at least a little bit of their lamina propria. They're surrounded by at least a little bit of their lamina propria, and also muscularis mucosa, some smooth muscle. The problem is that sometimes these glands become obstructed, they dilate, they rupture, and the mucin spills all over the place, and some of the cells acquire this signet ring cell-like morphology that is reminiscent of signet ring cell carcinoma. But in this context, you should refrain yourself from providing a diagnosis of signet ring cell cancer when you have all these other features. Many of these polyps with pseudoinvasion are going to have tons of hemosiderin-laden macrophages, which is also a helpful clue when you're trying to decide between invasion and pseudoinvasion. Doesn't make it, doesn't break it, but it pushes you to look for other features such as associated lamina propria and rounded big glands. This is another example where you had glandular rupture and spillage of mucin dissecting into the submucosa. Here's another example where you don't have as much glandular dilation and rupture, but you have tons of misplaced glands being pulled right, and you can see them connect here to the surface and being pulled down into the submucosa, and you can see the hemosiderin from this tower associated with these areas of pseudoinvasion. When you look on higher magnification, you can see the lamina propria is being dragged along with the neoplastic glands in the absence of tumor-associated desmoplasia. These changes are very common in patients with Peutz-Jeghers syndrome. Sometimes patients develop in this setting, so Peutz-Jeghers, these patients develop Peutz-Jeghers polyps in their small bowel, colon, and stomach, and many of them have this tremendous, very dramatic, exuberant, pseudoinvasive pattern where, again, the glands are being dragged down, all the way down to the muscularis propria, but again, you can see an associated lamina propria being dragged with these lesional glands. Some of them just as in the previous example, undergo glandular dilation, rupture, and also mucin extravasation. And we receive these kinds of cases a couple of times a year with people wondering about a well-differentiated adenocarcinoma in patients with Fuchs-Jaeger's polyposis, Fuchs-Jaeger syndrome. And just to compare, I don't have a polypectomy with invasive cancer, but I got this slide from a resection case so this is what I want to see in the setting of invasion. I want to see ill-formed, angulated glands with an associated desmoplastic stromal response. These glands are devoid of an associated lamina propria. Here we don't have a lot of hemosiderin-laden macrophages, just the stromal desmoplasia around these neoplastic glands. And these pointy, I love seeing these pointy glands to me are very suspicious for an invasive cancer, as opposed to the rounded bulbous configuration of glands in the setting of pseudo-invasion or glandular misplacement. Okay, so that was my last case, and we are done. So we apologize for the technical difficulties, but it does happen. Thank you, Dr. Manan, for working things out. Are there any questions from the audience?
Yeah. So we apologize for the technical sluggishness, and there is one question from online audience, like on Facebook. So the question is, I think it's about how to differentiate between desmoplasia and real pseudo-invasion.
How to differentiate desmoplasia?
Yeah, desmoplastic response and epithelial. So I think it's about desmoplastic response and pseudo-invasion.
So when you see real desmoplasia, such as here, you see that very pale stromal reaction surrounding neoplastic glands. And of course, the desmoplastic reaction alone will not exist by itself. You're going to see it along with the glands that are typically, pointy and ill-formed. But typically, it's a paler quality to the fibroconnective tissue, paler, looser quality, as opposed to the areas with pseudo-invasion, where what you see surrounding the actual pseudo-invasive glands or the misplaced glands is either lamina propria with, the associated lymphocytes and plasma cells, and it's a little bit loose, but you get that inflammatory component, or very pink smooth muscle, very pink dense smooth muscle. So pseudo-invasion, no desmoplasia, lamina propria, and fibromuscular tissue, and then real desmoplasia is going to be very pale myofibroblastic response to the invasive tumor, and here it is. All right.
Just I myself would like to reiterate that point of the case that we see it so often that the question is about pseudo-invasion, and whenever there is mucin extrusion, so we sometimes tend to think that it is probably invasion while it is not, right?
Yeah, exactly. And the truth is that sometimes we can't tell. Mm-hmm. So in some cases are very, very challenging, and we just have to tell the truth. We believe this is pseudo-invasion, or we believe this is invasive, but we're not 100% sure. So, I mean, we also struggle with these difficult cases that are sent in consultation, and when we don't know, you just have to say you don't know.
So then we have to explain it in a comment.
Yeah,
right?
Exactly. And you just write a careful comment saying what are the features that you see where you favor this or that, and why you can't be definitive on your diagnosis one way or the other.
Right. Thank you, Dr. Voltaggio, for the thorough overview of the colonic polyps. We appreciate it so much. And thanks for the audience for joining online. We again apologize for the technical lag. And thank you for joining today's podcast. And as you know, you can find an archived version of Dr. Voltaggio's talk by visiting YouTube channel, Facebook page, and also we are launching a website, so which will be pathologycast.com. So so we would type it in so that everybody can look into the archive talk in that website. So up next, we will continue our multilingual series, which we had initiated yesterday. So that would be the multilingual series introducing the Milan system for recording salivary gland cytopathology. And we will be joined by Dr. Calagari, who will be speaking in Portuguese on December 4th, and Dr. Urano and Lucy, who will be presenting the system on December 19th in Japanese. So I hope you guys enjoyed today's podcast. Please follow and like our Facebook page and share the lecture with your colleagues. And until next time, goodbye from Baltimore. So this is Rifa and Emilio, who is there in Atlanta, Georgia.
Thank you everyone for joining.